Grella.
Okay. Thank you. Thanks for inviting me. I'm very happy to be here today. And what I'm hoping to do today is to engage you in a somewhat different perspective on thinking about substance use disorders, which has to do with what we call a life course perspective. And with the integrated substance abuse programs at UCLA, and our group at UCLA does many longitudinal cohort studies studying substance use disorders over the life course, and I hope to give you a flavor of that today. Okay. One of the questions that we ask if we think about substance use disorders from a life course perspective. How do they change over time? What are the factors that are related to initiation and change in substance use disorders? Obviously, great public health significance in wanting to change the course of these disorders. Are there critical events or cumulative events that increase the likelihood of long-term abstinence? We're all very interested in reducing the problems related to substance use. What are those factors? I tend to do a lot of research on treatment and treatment interventions and how to deliver treatment. And of course, we think about treatment as one type of intervention. We also have criminal justice interventions, and our group does a lot of work looking at those as well. We often talk in terms of trajectory of substance use disorders, how the patterns of substance use change over time, and how are these influenced by individual characteristics. So again, I'm hoping to give you just a sense of the kind of work we do way of conceptualizing substance abuse disorders. So in the first point I want to make is that often when we think about intervening with substance use disorders, we thought about it in terms of a classic acute care model, which is we develop an intervention. It's rather brief. We're all very concerned about cost of health care. We want to have a very expedient intervention, and it's based on, in terms of substance abuse treatment, perhaps a 7-day course of treatment. If you're lucky, you might have a 30-day course of treatment. How much will your insurer be willing to pay for if you have insurance payments? With the exception, I might add, of opiate replacement therapies, which are conceptualized as long-term treatment. You may, after you go through an initial course of treatment, be referred to the community for what we call a step-down, lower intensity treatment. You may be referred into 12-step programs in the community, but these are not contextualized within the treatment context of managing the long-term course of this problem. And thus, when we go to measure the outcomes of our treatment, historically, people like me who are trained to think about substance abuse treatment would look at perhaps a 3-day outcome, maybe a 3-month outcome, 90 days, or even 6 months or 1 year. But when we look at the life course perspective, we'll see how thinking about outcomes within those time frames is quite inadequate. And what are we thinking about substance use disorders as chronic disorders, much like other chronic disorders. So you may be familiar with this kind of analogy that's been made. The substance use disorder shares certain characteristics with other chronic diseases, such as asthma, hypertension, diabetes, depression. All of these disorders require that we change behavior to some extent. People have to be very involved in their treatment. They have to manage their disorders in concert with healthcare providers. So there's a great deal of behavioral change that's required in managing these, and we don't expect that they're going to change over a 7-day course of treatment. We wouldn't expect somebody with diabetes to go in to see their doctor, get prescribed insulin treatment, and then we tell them goodbye and we don't check up on them. We expect to have continuing care, or what we call continuing care. The other thing that substance use disorder shares with these other chronic disorders is that adherence is notoriously poor. If we think about treatment for substance use, often the image that comes to mind is that people are in and out of treatment. We may have friends, family members, we may be in media, people that relapse is very common. So it gives substance abuse treatment a very bad name. The common perception is it doesn't work because people go into treatment and then they relapse. And yet when we look at these other disorders, asthma, again, blood pressure, maintenance, regulation, diabetes, we know that people have a really hard time sticking to their treatment regime. That in fact, if we think about relapse from treatment from those disorders, treatment adherence, that's also quite common. And then instead, again, we need to think in this continuing care model and look at what we think of as outcomes over a much longer period of time, what I would argue, again, is the life course. And this analogy made, again, looking at broadly defined relapse rates of other diseases. So if you look at type 1 diabetes, again, adherence to behavior, dietary changes, medication adherence, same with hypertension and asthma. And in fact, these are large averages over many studies, but people adhering to treatment, following substance abuse treatment, following behavior protocols, are relapsing at about the same range as these other long-term chronic diseases. So that's one of the first things we do, is try to reconceptualize how we think about substance use disorders. Again, some of the questions that we might want to explore, thinking from the perspective, have to do with critical life events, initiation, when is substance use initiated, how early, does it matter when you begin experimenting with these different substances in terms of the likelihood of onset of longer-term disorders. Coerced treatment is something that we've been very interested in terms of criminal justice interventions. We have in California Prop 36, which gives people the option to go into treatment, substance abuse treatment, if they're arrested and they're a nonviolent offender. And the voters of California passed this initiative, but we also can force and mandate people to go into treatment. Does this work? Developmental processes are incredibly important in terms of the initiation and course of substance use disorders. When we think about youth, the factors that impinge upon their substance use, they may have less established routines. They're developmentally establishing themselves as independent adults. They may lack a sense of self-efficacy, which is very much important in terms of adhering to the kinds of treatments and long-term course of change that I've been talking about. And they're extremely care dependent, as we heard a moment ago in terms of tobacco use. Older adults with longer-term substance use disorders have many other influences on them, such as family, particularly women who are substance users or children. They have family pressures that may influence their substance use trajectories, work issues, and health issues as health problems begin to manifest over the life course. So where someone is in their developmental stage has a large effect on how we think about intervening with them and treating them. And then the question of aging out. For a long time, it was believed, well, people eventually slow down. It's hard to keep sustaining drug use behavior. There's actually a lot of effort required in procuring and using substances, and people they simply burn out. And some of our work has examined this over time. Is that true? Do people age out if they don't die in the process, I should add? And the issue of mortality is extremely important. We know, and I'll show you some data on the very high mortality risks in the case of my study associated with heroin. And we know that sustained abstinence over time greatly reduces the risk of mortality for people who have histories of substance dependence. So if we look at the population, and if we look at population survey data, there is a high rate of experimentation with many substances. I'll show you some data in a moment. Alcohol, nicotine, marijuana, most frequently used substances in the population. But actually, very few people in the population transition to problematic use or what we call dependence. When I talk about dependence, I'll be using the clinical understanding of dependence based on DSM criteria, the psychiatric diagnostic criteria that denotes dependence, meaning people have had problems with the use, they cannot stop despite the problems. We know that among people who report any substance use, and I'm talking across substances now, that their probability of moving from simple use or experimentation to more problematic use, which we typically call abuse, to clinical dependence. We know that people who have a family history of alcohol or drug dependence are more likely to transition into problematic use. Those who have co-occurring psychiatric problems, depression, anxiety, schizophrenia, other psychotic disorders, more likely to transition. Those who are dependent on other substances are more likely, on one substance, more likely to develop dependence on others. There's many reasons that account for this, cultural, environmental, biological, genetic. We also know when we look at transition probabilities differences among racial ethnic minorities with higher rates of transitioning from use and experimentation to dependence, depending on the type of substance. So I'm just going to show you a little bit of data from a national probability survey called the NIDARP study, National Epidemiological Survey on Drug Use and Dependence, conducted in the 2000s. And these curves are cumulative probability curves that show the probability of transitioning from any use, so simple use, experimentation, probability of transitioning over time to dependence. And what we're looking here is at the steepness of the curve. So let's see if I can put a parcel out. It's really hard for you to see the legend here. The most rapid onset is with cocaine, which is the triangle. Most steep transition from use into dependence, as well as cannabis. Much more gradual transition for alcohol. And we can see the most gradual transition for nicotine, but the highest cumulative probability of moving from any use to dependence. So again, any experimentation, cumulative probability over the life course, highest for nicotine, but more gradual. And I think Professor Benowitz's talk earlier gave some reasons for that. Greater experimentation among adolescents, much earlier age of initiation, more gradual experimentation, but much higher cumulative probability of transition dependence over time. This slide shows the same data but depicted in a different way, which is the rate, the cumulative rate of transitioning from any use to dependence. And again, you can see the extremely high rate among nicotine, less so for alcohol. And I should add our two legal substances, more available, more access, more availability that might promote their use, more social acceptance of their use, and the lower rates of transitioning from any use, experimentation to dependence, cocaine and cannabis, more restricted substances, and also more visible, immediately visible negative problems, especially with cocaine. This slide, also using national survey data, in this case the National Household Survey, arrays data from the population by age group. And what it's showing here is that, again, substance use disorders, and this is looking at a variety of substances, alcohol, drugs, that in the general population, it's, whoops, uh-oh, it's, again, only a minority of people. We see here the peak of abuse and dependence between 18 and 29. These are the peak years for substance abuse and dependence. But it's a minority of the population. This is arraying the whole population. So this is regular but less problematic use, infrequent use, and no use. So substance use disorders are very much a problem of young adults, as we know, in terms of the peak years. And again, it's a minority of the population, but this is the part of the population that is incurring a high degree of individual problems and high risk to society as well from the consequences of substance use. This data also taken from the NIDARP, the National Epidemiological Survey, showing the converse of what I showed you earlier, which is the probability of remission from dependence. Again, using a clinical diagnostic threshold of remission. So from the age of onset to remission from the different substances, and again, we're looking at the steepness of the curve, and we're seeing a more rapid period of remission, rate of remission or time to remission for cocaine, cannabis, and much more gradual, again, for alcohol, nicotine. Again, the longer periods of duration, lots of reasons here again, physiological, social, in terms of access, availability, social support for use, continued use. So the substances act differently in terms of their context, but what we're seeing are, for many people, very long life course problematic substance use. And again, this is showing the same data about the cumulative rate of remission, probability of remission from the different substances. So over the life course, most people who develop problems, abuse, and dependence are remitting. But again, the lower rate you can see for nicotine, alcohol, and the higher rates for cannabis, cocaine. I'm actually somewhat interested in what we might expect to see happen with cannabis, with marijuana, as it's moving from, and of course this is very controversial in California, as with so many other phenomena, is at the forefront of change in this area, policy change. But we have a very contested status to marijuana right now, so its access is becoming much greater than it has been in the past, and whether that changes some of the duration of long-term use and dependence on marijuana, I think it's something that we need to start looking at immediately. So moving into intervention. So a certain portion of the population, although a small portion of the population that uses a variety of substances, transitions into long-term problematic use, dependence. And at some point, they may encounter a need or be forced into an intervention. Based on a variety of studies, we've seen that the median time from first use to at least 1 year of abstinence is 27 years. Again, collapsing across many, many studies. A long time for people to be incurring individual harm as well as harm to society and to others. Moving into treatment, median time from first treatment to first abstinence is 9 years. Again, this may underlie the sense that treatment may not be perceived as very effective when it takes so long to achieve what we see as the critical outcome, which is abstinence. We know that people who go into treatment among those who have dependence disorders are different from those who don't. Again, more severe disorders tend to mark people who go into treatment. The people going to treatment are those with the hardest to treat. They are the ones with co-occurring psychopathology, co-occurring mood disorders, anxiety disorders, personality disorders, and they have multiple problems across multiple domains. So by the time one of my frustrations as a treatment researcher, people, their perception that treatment isn't very effective, you're asking treatment to do a lot. People walk in the door of a treatment program, they have lots of problems. We also know that the course of substance use disorders is highly unstable. So this is summarizing data from one particular study over a 2-year period. And we've actually replicated this analysis as well. And what it's showing is we're looking at people's movement across 4 states. In the community, actively using, incarcerated on the top, the green box showing in the community in what we're calling recovery, which is no use and no legal involvement, and the bottom in treatment. And what the percentages represent is the percentage of the group that is moving from one state to another. These are not sequential. It's movement. It's any movement over time. And the point is like people are moving around constantly from using into treatment, into the community, not using, into incarceration. And we've done a lot of analyses looking at the different predictors and modeling the different factors of moving from one state to the other. So this is the point about why studying treatment outcomes at 30 days, 60 days, 90 days gives you just a snapshot at one point in time, which is not very representative of the course of these disorders. This is only over a 2-year period, but again, over a lifespan. So to illustrate with some data what I mean when I'm talking about this perspective, I want to share some data with you from the study that I conducted. As I mentioned, our group at UCLA does a lot of longitudinal cohort studies, and I'm very interested in looking at gender differences in longitudinal trajectories of substance use. A lot of the studies that our group had done when I became involved, tended to be sampled from, they were all male cohorts because they were sampled for criminal justice settings in the 60s and 70s when women weren't predominant. So just by logistical facts, the samples from our original cohort studies tended to be all male. So we had a historical archive database of patients who've gone into methadone treatment in the 1970s in California. So we had baseline data on all of them, very extensive data on their background, very extensive data on their drug use up until that point. And we were able to get funded for a study to recontact them to do a follow-up wave. They were all sampled from methadone maintenance treatment in Southern and Central California. We included all the study participants in our attempt to follow them up and locate them. First, we did a mortality analysis where we verified if they were living using a death record search. We found, this is our first finding, that nearly half of them had died. We know that heroin users have a very high rate of mortality, but again, I was interested in gender differences and looking at that. Of the 71% that we did not confirm were deceased, of the remainder who were not confirmed as deceased, we located and re-interviewed 71%. We're very proud of that rate. Many of these people were quite ill. There were another 5% or so who could not be interviewed because they were, in some cases, literally on their deathbed. So we actually contacted close to 80% of the original cohort that was still living. Their average ages, you can see, 58 for males, 55 for females. So these are the baby boomers that were using drugs in the 70s. These were all heroin users. Again, they were sampled for methadone treatment. And you may have heard yesterday the CDC issued an announcement that all baby boomers in this age cohort should get tested for hepatitis C. That is a new directive coming out of the CDC. And it's for the reasons, some of the reasons I'll be showing you in this study, that there were people who were injecting heroin, other drugs in the 70s, who are now the baby boomers who are aging, who perhaps coming in for a general health checkup, one wouldn't think to say, did you ever inject drugs? They wouldn't be presenting in stereotypic ways that would prompt a physician to ask that question. So now the directive is to test everyone regardless in this age group. So it's very much that age cohort. So I'm going to data on the mortality and then just show you a couple slides on what we found out about from those who are still living. So these are the causes of death arrayed by decade. And not surprisingly, overdose is the predominant cause of death for those under 40. Liver disease, this was because there was a high rate of comorbid alcohol use. And again, we see that substance dependencies tend to go together. And I should say that in the remaining cohort that we interviewed, the alcohol use was not that high. There was not a lot of problematic alcohol use, I think because so many of the alcohol users had died. Cardiovascular suicide and homicide, at much higher rate than you would see in the general population. Again, primarily though in the under 40 cohort. Overdose decreasing over time as we would expect. Other diseases that are common with aging increasing over time, cardiovascular. But again, the very, very high rate of liver disease as primary cause of death among this cohort, and cancer. So direct mortality from drug overdose, predominantly in the under 40, but other drug-related and associated causes of mortality. Average age, looking at gender and ethnicity, significant differences for females dying at about 46 versus 50. Non-Hispanic whites has the largest effect as compared to African Americans and Hispanics. And I interpret this to mean because African Americans, Hispanics facing greater burden of disease from many other sources. Thus, the impact of addiction was less so on reducing their lifespan, but nevertheless did have an effect. And then when we view that in the opposite way, years of potential life loss, controlling for age, gender, and ethnicity comparisons in the general population, you can see the years of potential life lost, about 25 for males, 25 for females, and so on, ranging from 25 to 33. And these are standard mortality ratios. So this is the risk of death compared with their counterparts in the general population. So again, ranging from about 3 to 5 for males and females, and so on. Okay, so in the short time remaining to me, I just want to give you a flavor for the kinds of, again, analyses that we do. And it's rather complicated. I'll walk you through it a little bit. What we do in our studies is a technique that's called group-based trajectory modeling. So we have our interviewed sample, the 371 that we were able to re-interview 25 years later. We linked their follow-up data with the baseline data that were collected in late 1970s, early 80s. So we have 30 years of linked data on their substance use patterns over time. And we have lots of baseline data that we collected 25 years ago on their childhood and family that we can look at as prospectively used as predictors of these trajectories. And what these trajectories are, it's a method for trying to partition the sample by finding groups, clusters of individuals that share common behavior over time. So it's a longitudinal analysis looking at behavior patterns over time and how people cluster in similar groups. So what we find, this is looking at patterns of heroin use over 30 years. So we have 4 groups that cluster. The rapid decrease group, which is about 25% of the sample, is the red line. The moderate decrease here, about 15%. The gradual decrease group, and the no decrease group. So that's the group that persisted. About a quarter of the sample persisted in active heroin use, injection heroin use throughout this period of time. So those are the baby boomers that didn't age out. So we do see some aging effect, but we see a quarter of the sample that does not. So then we look at, well, how do they differ? Are there characteristics that, from the baseline original data that we can use to discriminate among these groups? And in fact, there were some very interesting ones. And luckily for me, because I was interested in gender, there were some gender effects. There were a greater proportion of women in the rapid decrease. I should say rapid decrease is relative in terms of name. The mean time to zero probability is about 12 years. So it's not really rapid, but in terms of the lifespan, it was. But that's still a long duration of heroin use. Other characteristics that I found very interesting, that the rapid decrease group had less what we call externalizing problems. So in the original survey, there were questions about early childhood psychopathology that was manifest, such as through school problems, being expelled from school, etc., and some indicators of antisocial personality. So that most rapid decrease group had less of that. And then when we look, but what was very interesting when we looked at their other substance use, because again, we do a very detailed assessment of all of the substances used over the time frame, they had higher rates of alcohol and methamphetamine use. And this is extremely important because often in our outcome studies, we're looking at a primary substance, and what we might say, great, they're aging out of heroin use relatively rapidly compared to these other groups, but they're also using high rates of alcohol and methamphetamine. Can I finish? Okay. The no decrease group that's that group at the top, the blue. They spent the most time in methadone maintenance. This is a challenge for a treatment researcher because I think presented to the public, they're going to say, oh, great, people who go into methadone maintenance are using heroin the most. To me, that makes sense. They were moving in and out of maintenance therapy. That was preventing them from overdosing and dying. So to me, I saw it as a harm reduction approach. Again, it's hard because the public doesn't have a high tolerance for thinking about maintenance therapies. Finish up. 2 more slides. As I mentioned, we saw that their other substance use was quite prevalent over the lifespan. And so we didn't want to just look at heroin cessation. We wanted to look at other substance use. So we did the same procedure. These trajectory models were done jointly, actually, so they're controlling for each other. And we saw 5 groups here when we looked at their alcohol and other drug use patterns. So a little bit more complex than the heroin use groups. We had a group that used very little alcohol and drugs, other alcohol and drugs besides heroin, and this was controlling for time incarcerated. That group, interestingly, was the most criminally involved. So they seem to have a very cogenic profile. And then various patterns here, a group that used about half of the time, but in the latter half, another group that used about half the time, but in the And then another group that had very high rates of use sustained over the 30-year period. Again, the baby boomers that are still using. And one of the conclusions we took from this study is that indeed there is a significant portion of individuals who develop substance use disorders actively using something that persists in use. And then we need to think of age-appropriate interventions with them. Where are they encountering the healthcare system? What kind of healthcare needs that we anticipate having as they age? So this is just descriptive statistics on the characteristics of the trajectory groups, which shows you how nicely it's arrayed in terms of their earlier age of first substance use. The age of first use goes down the longer the persistence of use, and the average duration of use, and the age of last use. So giving nice validation to our trajectories. So just to summarize, I hope I give you a flavor for thinking about substance use over a lifespan, why when we think about outcomes, we need to expand our view. It has real implications when we think about treatment, we understand treatment and how we need to convey the treatment needs of substance users. With a particular cohort that I examined, we saw some very interesting associations, I think, between gender and early childhood psychopathology, which may be related to some perhaps latent groups that of characteristic clusters of traits that are extremely important to intervene with early because they have long-term consequences over the life course. So I'll end there, and perhaps there's a moment for questions.
Thanks so much. Fascinating talk. Let's take one question, and then the speakers will say afterwards, hopefully.